Yes, we can hear you.
Okay. So quickly, I'm going to discuss this sickle cell disease because it's a recent love of college and they are giving quite frequently. It may come anyways, like it may come as SD, it may come as SPT. In SPT, there may be a situation that patient has been admitted with some pain, acute pain, or maybe acute chest syndrome. So you should know how to start the task, right? So this is all we are going to discuss here. That is preconception counseling, antenatal counseling, antenatal care, intrapartum, postpartum, and definitely in the end, some important points will be covered. So you can cover SPT or SD, whatever way it comes in exam. So SCD, definitely first it is going to be introduction, agenda, and consent for asking questions. Now, after that, going to be HOPI. HOPI will include pregnancy. HOPI will include condition. So in pregnancy, how it has been so far, taking folic acid, what's the strength? Because here we take 5 mg, so asking this is very important. Any symptoms, planned or unplanned? If unplanned, then which contraception and address effective contraception? Because in SCD, preconception counseling considered very important. So if unplanned, then definitely you have to address effective contraception and refer a reference later on for avoiding any unwanted pregnancy. If planned, then ask whether it was spontaneous, what is the gravida, and other details. In complaint in early pregnancy, normally you ask any pain in tummy, any false smelling discharge, bleeding, or vomiting. In this condition, even if you ask that any complaints and she says everything is fine, I would suggest you to ask specifically for vomiting because vomiting is one thing which can aggravate the condition because it is a predisposing or the risk factor. Am I clear so far, girls? Now coming to condition. Please tell me about your condition. What all question should be included if she is not informing herself about everything? Any other medication like other than folic acid? Any other medication like antibiotic? Because here we give penicillin prophylaxis. If someone is allergic to penicillin, then it is erythromycin. When did you see the team last? Did you speak to team about pregnancy? Latest heart scan, spatial heart imaging like cardiac MRI, because we do cardiac MRI to rule out any kind of iron overload. Eye checkup, blood test to check how kidney and liver functioning. Any blood transfusion of late, especially hospital admission, vaccination like flu, hepatitis B, pneumonia. If taking hydroxycarbamide, then when did she stop? How are you coping? If she is finding difficult, offer support and counseling. Then and there, this is very important. So am I clear about HOPI? Girls, say yes or no. Uh, I want one volunteer who will quickly just speak about HOPI. How you are going to address HOPI. Any volunteer, please. Any volunteer. Exam is around the corner. Now you should be confident. And you have to just read and speak, no? Anyone? Anyone? No one wants to speak? Should I go ahead?
Recording in progress.
Girls, you are unable to unmute. Just a minute. So, who wants to speak? I'll. Whoever whoever wants to speak, just type. So I'll unmute that girl. No one? So I'll go ahead. No issues. Akansha, Anam, Atia, Manikam, Monica, Yashasvi, and some VK.
Ma'am, the patient has come pregnant. We should ask about whether she's taking folic acid 5 milligram and about whether it is a planned or unplanned pregnancy. If it is unplanned, we can tell that she'll be offered the contraception advice after delivery. And she has come for, I mean, the pre-pregnancy counseling. We'll do all the investigations which are required for her. And we should also, if pregnant, we should ask about her whether she's having severe vomiting.
Correct.
And,
And what is the
and whether
importance?
she's on any prophylactic antibiotics.
Yes. What is
And
the importance of asking vomiting, Manikam?
she may go for a dehydration and then can precipitate her sickle cell crisis.
Absolutely, absolutely. Perfect. So these two important thing about HOPI, ask about pregnancy, specifically about the vomiting and the strength of folic acid. These are two very important HOPI point which differentiate it from other conditions or other diseases in pregnancy. After HOPI, definitely you are going to continue with your information gathering. You will ask about the last menstrual period. If scan is there, then scan is corresponding to weeks of pregnancy, cervical screening, medical history, drug allergies, surgical, family, anyone else has condition or history of DVT becomes very important here. Partner being tested for this condition. This is again a very important question which you are going to ask in family history because it is going to decide about the inheritance in offsprings. Support at home, mental, smoking, and examination. In examination, you are going to check her chest, you are going to check her heart. If ultrasound is not being provided and patient is coming with early pregnancy, always make a rule of checking her tummy, that I'll check your tummy for any pain on touch, and you will definitely ask shoulder tip pain because you do not have any scan. So ectopic pregnancy purpose, you will rule out shoulder tip pain and you will definitely ask about examination of tummy if there is any pain on touch in lower tummy. If you have a scan which is showing intrauterine pregnancy, then this you can skip absolutely. Now coming to second part of the task, which is definitely very important. And I understand that sickle cell disease is little bit difficult. So I try to make it simple for you how you are going to present in SPT. First, you check her understanding about condition, then say, most of the women with condition may have straightforward pregnancy and healthy baby, through few may have some concerns. Would you like to know about it? Then effect on mother, baby, and effect of pregnancy on condition. You will mention all three. Then immediately offer her care under expert team, that is pregnancy doctor, SCD team, which includes specialist doctor and nurse, specialist nurse, midwife for this condition. Counselors are very important. Imaging doctor, later on baby doctor and pain relief doctor. So this is how you are going to start your second part. First, check her understanding, then say this like kind of signposting that how you are going to take care of her, and definitely a good BBN she deserves. A moderate BBN she deserves here. Reason being because it is not going to be easy for her. So moderate BBN is very important here. So you'll start second part with this signpost. First ask condition, then signpost, then moderate BBN, then tell her effect on mother, baby, and change in the condition, then immediately offer her care. This should be your format in all the antenatal and maternal medicine. Condition, Signposting, BBN, then effect on mother, effect on baby, and effect on condition. Immediately after, offer her MDT, because MDT becomes very important in all maternal medicine and of course antenatal, because it is very clear that you are not going to get any low risk pregnancy in task or to present a task. That is for sure. Now, complication of SCD. If she is not aware of general complication of SCD, then definitely you are going to mention all these. There can be acute painful crisis. There can be acute chest syndrome where you might be having some fever or some breathing symptoms, blood clots in legs and lungs. There is increased blood pressure because of the, or increased blood pressure in lungs. You can say this way, some heart conditions, eye condition, kidney won't be functioning properly. You may have some ulcers in leg, and then cholelithiasis is also a complication of SCD. So there is stone formation in gallbladder, and there could be avascular necrosis, means some tissues or some parts may be dead because of no blood supply. Now, details of condition. Probably she would be aware of details of condition. She won't be asking you, even if someone asks, can you tell me about my condition? Abnormal sickle hemoglobin, that is blood strength particle in low oxygen condition, leading formation of rigid and fragile sickle-shaped red cells, prone to increased breakdown, causing hemolytic anemia and occlusion of small vessels, causing acute pain. So basically, there is abnormal sickle hemoglobin, which is a blood stent particle, which is responsible for this condition. Simply, there is one abnormal sickle hemoglobin, which is a blood stent particle, which is abnormal in this condition. And how it works? It works by changing the shape and increasing breakdown and closing occlusion of small vessels. So this much you should know if she asks. Now, effect on mother, high blood pressure, protein in urine, infections, especially waterwork infections, sudden anemia, or you can say low blood strength. Anemia, you can say low blood strength. Okay. And then lung problems and blood clots in legs and lungs. As far as baby's effect on condition is concerned, then there may be painful crisis, there may be hospital admission, there may be a special condition where you will be having fever and breathing symptoms, worsening of condition, worsening of kidney, heart functioning, and eye changes. So these are the effect on condition. After that effect on baby, there may be early pregnancy loss, small in size, poor growth of baby, delivery before time, and can have same condition. As far as these three are concerned, small in size, poor growth, or delivery before time, 99% maternal medicine condition, you can use this. If you do not remember anything specific, at least say these three things on effect on baby. After that, so it is condition, then signposting, like some may have concern, some may have this thing, then moderate BBN, then effect on mother, effect on baby, effect on pregnancy, and immediately after that, MDT. After MDT, you are going to say there will be consultant, you will be seen in consultant unit. There will be expert team care, frequent visits. Each visit, you will be checked for urine protein in urine, assessing for blood clots in legs and lungs. This is in every visit we are going to do. Then you will discuss about all the medication in one day. Folic acid throughout pregnancy, vitamin D3 10 mg per day, though they recommend this in all pregnancy and breastfeeding. This is a basic protocol of RCOG, but in this condition, they specifically insist for this. At times, they do ask for checking for vitamin D3 deficiency. Aspirin, earlier it was 75, but current change in guideline is 75 to 150 from 12 weeks as a risk of preeclampsia, and at 36 weeks, team sits again and decide whether we need to continue. Normally, they stop. So I repeat, aspirin 75 to 150 as per new guideline from 12 weeks up to 36 weeks. At 36 weeks, they may have another meeting whether we need to continue. Probably they will stop at 36 weeks. Blood thinners need to start if BMI high, may continue after delivery for 6 weeks to reduce blood clots. It's a very important patient safety point if you speak about SCD in pregnancy. Daily dose of antibiotic, usually penicillin, need to take or continue. If allergic to penicillin, then erythromycin. So were you aware of this fact, girls? Just raise your hand. Were you aware of this fact that if there is penicillin allergy, then we have to give erythromycin? I'm just waiting for your responses in chat box. How many of you were aware of this, that we need to offer erythromycin if they are allergic to penicillin? How many of you? Yes, Atya was aware, Maya was also aware, and Manikam was also aware. That's perfect. That's perfect. It means you guys are really going through material and the authentic material. Lovely. Eye, kidney, heart assessment at first appointment. This is very important because we do not do eye assessment frequently later on. So this is a very important point, that eye, kidney, and heart assessment in very first appointment we have to do. Vaccination like flu, hepatitis B, pneumococcal, meningococcal, you are going to discuss and offer. Who is going to tell me what is the regime for vaccine? Type, girls. Who is going to tell me what is the regime for vaccine?
Meningococcal is one of pneumococcal is every 5 years, and influenza influenza is every year, um, and hepatitis B is as per schedule.
And we can offer booster dose in hepatitis B if team decides so.
Yeah, we have to check the levels, and then if the levels are not, yeah.
Simply say booster dose for hepatitis B may be offered as per expertise suggestion.
Yeah.
So meningococcal always once, hepatitis once, maybe with booster dose, but H influenza with type B is also only once, right? But for swine flu and the general influenza, that is flu, every year, that is annually. Am I clear, girls? So nobody is saying yes or no, so I'm just moving forward.
Yes.
Lovely. Now, a repeated full blood count. So you will say that repeatedly we are going to check your blood strength, blood clotting, how your liver is functioning, kidney is functioning, urine routine microscopic ferritin group, antibody screening throughout pregnancy. So we do it quite frequently. So do not need to remember, especially in SPT, how frequently, but you can say repeatedly. May need heart scan as well for pulmonary hypertension, heart MRI to screen iron overload, and eye checkup only if necessary. Because in new guideline, they are mentioning eye checkup only in the beginning. So you can say only if necessary. Heart MRI is generally for the screening iron overload. Normally we do it before conception, because if there is iron overload, we have to do what we have to do. What we have to do? If iron,
Yeah.
iron chelation, definitely. Who was it? Who was it?
Aparna.
Lovely. But Because we cannot offer iron chelation during pregnancy. Why we cannot offer? What does it cause?
Baby problem.
Teratogenic. Okay.
Only low dose dysferoxamine can be given after 20 weeks.
Okay.
After
Lovely.
first trimester, rather, yeah.
Okay. Lovely. So everybody at this point as well. In each visit, blood pressure, urine, and DVT assessment, this we have already discussed. Now, blood transfusion if need arises, pain relief like PCM, coding can be taken. Pethidine is not given. Anybody, why pethidine is not given?
It leads to fits.
Lovely. Who was this?
Ramaparna.
Lovely. Swaparna is very well prepared. Chances of inheritance to babies, so refer to fetal medicine unit for testing. This is again a very important point because why it is important? Was there protocol for SCD if baby is having same condition? And what is the duration maximum?
I mean, if it's an autosomal recessive, so it will be checked because if anyone, if they are carrier or something, then partner will be checked again, and then the baby will be checked for the genetic.
If partner is having this condition, we will definitely, even partner is also not having this condition, we are going to refer to fetal medicine unit for the fetal medicine opinion for testing. If baby is positive for condition, not the carrier, we can offer, here it is clearly given that we can offer termination in first trimester, preferably within 10 weeks.
Yeah, I
Then
mean, if the
quickly-
baby is affected, yeah.
Then quickly all routine blood and scan, routine that Down syndrome and this and that you will mention quickly because you cannot waste time here. In case if you become unwell, this is something very importantly you have to mention her because being unwell is pretty common in a patient with SCD and in pregnancy. Then immediately reach hospital and emergency contact number. So this is very important, ASAP. At the time you may need admission and SDU, strong pain relief, oxygen to breathe, fluids in arm. Other causes for same symptoms would be ruled out and may need injection for antibiotic if there is any other infection. Your baby well-being also be checked. From 20 weeks onwards, ultrasound is done 4 weekly. This is a very important patient safety point. Everyone, please remember this. And 20 weeks joint discussion about labor plans and the pain relief. This is again very important. Now they have changed the criteria. Earlier they were doing every patient around 36 weeks, but now they may, I would say, probable plan around 28 weeks because in many conditions we plan delivery before 36 weeks. So this is a change in past 2 years in college guidelines. So be very careful about mentioning this, especially a condition like this. Do not miss it. And always say, when we ever discuss about labor plan pain relief, that patient wish will be entertained or addressed or considered. Because whatever is the situation, autonomy is the priority, the one pillar of RCOG. It is suggested to avoid triggers like dehydration, stress, cold weather, or extreme weather, you can say, or extreme temperature, you can say, too much of physical activity. This is again a patient safety point. If you do not address that, trust me on that, even if you have covered everything, you are going to get only borderline in patient safety because these triggers are very much responsible for deterioration of condition, having acute crisis, having acute chest syndrome. So these triggers are very important. Now coming to labor, labor will be definitely in a consult-led unit with the facility of SDU. This is again a very important point. Everybody has to mention this. You will be kept warm, well hydrated, reduce the risk of crisis in labor, may give fluid through a drip, would keep blood safe. would aim for vaginal delivery if no complication. LACS, this is a very important point that having SCD is not an indication of cesarean at all. One-to-one monitoring and continuous fetal heart monitoring would be done. So now quickly, any volunteer who wants to tell me about effect on mother, baby, and condition itself. One volunteer, please. You have to just read and speak.
I can say that. So effect on mother, if there is a disease, then it is going to be the worsening of the disease. So it can lead to acute sickle crisis. It can lead
This
to
is
acute chest
effect on condition, not effect on mother. Understand difference between three. Effect on mother, effect on condition, and effect on pregnant baby. So if
Right,
we're
yeah.
talking about effect on mother, discuss this.
Yeah, it will be then miscarriage, preterm labor, SGA, infection, PROM.
Okay. So
Mm.
I would prefer it will be more systematic because that also leaves a kind of impression on role player. If you have any lay examiner, that how not only well prepared or how systematic and organized as a doctor you are. Getting my point?
Yeah.
Okay. So this is in front of you, Maya. Tell me how you are going to do now. Okay, so now it's your time. Start from here. And I want a very systematic answer. And I'll change slide for you. No issue.
So you want the effect on mother,
I
then you
want you
want
to
the
start second part of the task, how you are going to start. Till effects.
okay. So I will first like to know from the patient how.
No. You are presenting task. You are
Okay.
presenting to role player how you are going to speak to role player. Skip role player parts, just keep on doing.
Okay. So the effect on mother will be it can lead to high blood pressure.
Start from here. Start from here. Second part, start from here.
So how much do you know about your condition?
Move on. Just move on.
Okay, so most of the time, if your disease is well controlled, then the disease will be not having much impact on the baby, and we do expect that the baby will be well. Only in certain conditions, when there is a deterioration in your condition, that is the time when it affects the baby, as well as it can have worsening of your disease. And this is the time when we need to care about your risk factors or your stressors.
Where is BB and Maya? Where is BB? Doesn't she deserve
But
BB?
ma'am, why we have to say BBN here? Because patient will be aware about the condition.
If patient is aware about the condition or effect of condition on pregnancy or baby, why patient has come here?
Okay.
Why patient
Sorry,
has come to
I
you?
joined late, so I missed on your first 5 slides. I thought that patient is
Doesn't matter. Maya, doesn't matter.
okay.
Always remember, my suggestion is that, but everybody is intelligent. If they want to take up this point, it's fine. If they do not want to, like they do not agree with me, that is also fine. But for my suggestion would be any such condition like this definitely deserve a good BBN. Okay, move on.
Okay. So I'm really sorry to say, but this particular condition, if it is not very well controlled, or if there are triggers or stress factors which can further deteriorate your condition, so that can affect the pregnancy as well as it can affect the disease, and it can have impact on the baby. So uh, it's very important for us to give you the best of the care. And what we are going to do is we are going to refer you to the complete multidisciplinary team. Now, this team is a combination of all the experts from all the facility, which includes your consultant-led care. And it will be also taken care by the specialist, who will be the blood doctor, which is hematologist, and also the specialist nurse who is working for this particular condition. and there will be counselors as well. There will be radiologists as well, and there will be the
Not
doctor who
use
will take care
jargons.
about
Do
the
not
pain.
use jargons, Maya. Kindly do not use jargons. This is SPT, no? So don't say radiology, say imaging doctor. Do not say MDT, say expert team. Okay? Yeah, move on.
Okay. So, and we will be also referring you to the pain relief team because that is one of the very important component of your disease. Now, I would also like to tell you now what will be the conditions or will be causing the complications in you as well as in the baby. Would you like me to go further? And if she's saying yes, then I will explain her that in case of baby, the baby may be having a little bit less growth as compared to others. It may lead to what we call as a small for gestational age. It can also sometimes lead to preterm labor. There is a small risk of miscarriage as well. And it can and sometimes we may have to monitor the baby closely by doing the serial growth scan. Also, for you, there can be the risk of increase in the blood pressure, and it can also lead to sometimes protein, which is, there is a particular thing which we check in the urine and which can come positive for you. Also, sometimes it can lead to increased risk of infections, which can lead to the weakening of the membranes of the baby, and that can lead to rupture of the membranes as well. If your red blood cell is not very good control, then it can lead to the generalized weakness, and it can lead to
Maya, you
low
cannot
red blood cell.
explain effect on mother, baby so long. It is taking too much of time. You have to speak so much in this condition, no? So try to make it shorter and do not use.
But if we are not supposed to speak the medical jargon, then how? Because then we'll have to explain each and every condition.
Simply, you will say that early pregnancy loss, baby may born with small in size, there may be poor growth of baby, delivery may be before time and may have same condition.
Hmm.
That is all.
Yeah.
Some delivery baby will not understand, right?
Yeah.
Same effect on condition. You may have painful crisis. You may need a hospital admission. There may be worsening of condition, worsening of your kidney and heart functioning, and there may be abnormal eye changes. You can have a special condition, we call it as acute chest syndrome, where you may have fever or sometimes breathing symptoms. Make it simple and short. Effect on mother, may have high blood pressure, protein in urine, infection like waterwork infection, low blood strength, there may be some problem in lungs and may have blood clots in legs and lungs. This is enough. Because you have to speak so much, Maya. If you will take much time, then how you see it is such a big task. It is a big task.
Yeah.
Right? Because we have to come back to preconception counseling if she has come with this. Or even if she has come with the acute chest syndrome, we have to mention about preconception counseling at least little bit. That before planning pregnancy, you have to address all these things. Right? So just try to cut short. And please be careful. So if you're not getting the right word, preterm delivery, it's delivery before time. Small baby will be born with small inside. There will be poor growth of baby. Baby may have same condition. And for miscarriage, early pregnancy loss, stillbirth, IUDs, that late pregnancy loss. Okay?
Yeah.
Okay, well done. So
Thank you.
now, well done, welcome. So now who is going to talk about this? Everything is written here.
May I, ma'am?
Who is this?
Ma'am, Aparna.
Yeah, sure.
Yeah. So, ma'am, you have to tell the pregnancy course.
Definitely by tonight. Sorry?
Ma'am, we have to tell the pregnancy course.
You just start from here and speak whatever I've written.
Achha, okay. So you will be followed under consultant at unit. There would be a team of doctors who will be looking at you, including your specialist doctor. There will be frequent visits. At each visit, blood pressure, your proteins in urine, and assessment for clot would be there. Folic acid high dose you have to continue throughout the pregnancy. Vitamin D along with it, and aspirin from 12 weeks to decrease the risk of blood pressure and proteins in urine. And blood thinners would be assessed according to the condition throughout the pregnancy. and if started, have to be continued for 6 weeks to reduce the risk of blood clots. Daily doses of antibiotics, penicillin for your condition has to be continued. If allergic, then erythromycin. Then eye, kidney, heart assessment would be done at first appointment and accordingly if the need arises. Vaccinations like flu should be given annually, should be covered annually. Hepatitis B as per schedule, pneumococcal every 5 yearly, and meningococcal 1 dose. These vaccinations are very
And what is one more we give it flu?
HIV, Haemophilus influenza,
That is once.
HIB once, yeah.
Haemophilus influenza type B
The
once.
B.
It's swine flu. Flu
Yeah,
means influenza and swine flu both. So either you can say just flu, or if you want to say influenza, then mention swine flu separately.
Separately, yeah. Repeat, we'll get the repeat blood counts, the blood works like CBC, kidney test, liver test,
They
urine,
do not call it CBC, they call it
complete blood
FBC.
count. Sorry.
They do not call it CBC there,
Okay.
they call it
Okay.
FBC. CBC we call it.
So, right. So FBC, LFT, test for kidneys, urine, routine test, some tests for the iron studies like ferritin, group and
To
antibiotic
check
screen through
iron overload. To check iron overload.
ferritin to check iron overload.
Mhm.
Heart scans as well as to look for any pressures, high pressures in the lungs, cardiac MRI to look for any iron overload and eye
Heart
checkup.
MRI, heart MRI, heart MRI.
Heart MRI. Okay. To screen for iron overload. At each visit, BP for urine, for proteins and DVT assessment would be done.
Okay, clear?
But here, why it is written only if necessary? Eye checkup we
Because
do
eye checkup
preconception.
is only given in preconception and the first appointment. After that, they have not given.
Yes.
Okay.
So blood transfusions would be done if the need arises. Pain relief medications according to the step ladder manner, starting from the middle form, paracetamol or codeines can be taken. NSAIDs from 12 to 28 weeks can be preferred. Pethidine need to be avoided. There are chances of inheritance to the baby. So baby would be referred to the fetal medicine unit for testing. Then quickly all repeat blood and scans would be repeated. In case anytime anyone becomes unwell with this condition, 24/7 number would be given. They have to come ASAP. And at the time, admission may be required, maybe in high dependency unit, strong painkillers, oxygen to breathe, fluids in arm, and the causes for the symptoms would be ruled out involving the specialist. Antibiotics may be required and everything would be baby friendly and your baby well-being would be checked. Serial scans 4 weekly from 24 weeks onwards. At 28 weeks, joint discussion about the labor plans and pain management, pain relief options would be discussed.
And
It is suggested, yeah, in pregnancy, there are certain do's and don'ts. It is preferable to avoid dehydration, any extremes of weather conditions like cold or hot, and overexertion. It is always advisable to have a good sleep. And delivery should be in the consultant-led unit with the facility of high dependency unit. You will be kept warm, well hydrated to reduce the risk of crisis in labor. You will be given maybe required fluid through the drip. Blood would be kept ready and we will aim for vaginal delivery if no complications, cesarean section. One-to-one support and continuous baby heart monitoring would be
so this
provided.
is a patient safety point that you will be kept warm and
Kept
be
warm.
hydrated. Everyone,
Okay.
this is patient safety point in your labor care. Okay. Next is post-delivery. So now we'll discuss post-delivery, how we are going to take care of patient.
Yeah.
Baby
So
handed over to baby doctor. Early eating, drinking, moving around. Encourage breastfeeding. Again, assess for VTE, that is DVT. We would offer spatial stocking, that is compression stocking. Blood thinner at least for 10 days or longer, say 6 weeks if LSCS, or if team decides so as per condition. Okay. Prick heel test, normally we offer this within 5 days. Effective contraception. Though we can offer everything, but what is the most preferred one in this condition? Who is going to tell me?
DMPA.
Why DMPA?
It
decreases
decreases
with sickle.
the
The
pain
sickling crisis.
And what is the other advantage?
long acting.
So we always prefer where there is less chances of skipping by patient. Right? So something like this, because it is going to be for 3 months, it is going to be 5 years, because anyhow, they do not encourage any kind of unplanned pregnancy. POP or progesterone is always helpful in reducing the crisis. Now coming back today, it is going to be support group, documentation for GP, consultant, SCD team appointment. Anything else I can do for you? Note, if patient is on, what is the name of the medication?
Hydroxycarbamide.
Or we have to stop when?
3 months prior.
3 months. If patient is already taking and conceived, then
We have to basically counsel her. We don't have to
we are
terminate the
not the
pregnancy.
one who can counsel.
We have to send her to
Yes.
fetal
You have to
medicine.
understand your limitation as ST5. Even husband is taking. Husband is also supposed to stop. You understand that? You were
Yes, ma'am.
aware of this fact, everyone? How many were aware of this fact that we need to stop for husband as well? How many of you?
Ma'am, but if husband is positive, means husband is not carrier, no? He's like diseased.
But
So
even
if he's diseased and if the patient is also diseased, then it is going to be like, obviously the baby will be affected then, no?
yes, but this is something which is not our concern. If both are unfortunately positive,
Hmm.
it is there, right? But here
Yeah.
that's not the concern. I always suggest you everyone, please do not distract yourself for very complicated scenario, which is not going to be a case. Only if in
Hmm.
history they ask this question, you should be aware of that. It's my humble request to everyone. Think like ST5. You are just a ST5. Okay?
Ma'am, also, NSAID, are we giving in sickle cell disease or is it contraindicated because of the renal toxicity?
You tell me.
No, that's what I think it is contraindicated. What I remember.
It is
No.
not
Because of the-
contraindicated as such. If it is renal is affected, then definitely you maybe need to be cautious about that, but definitely it is not contraindicated. I'm just going to go there. The next slide,
Yeah.
you come to know about that, okay?
Yeah.
Preconception counseling. The probably patient might be taking this, so need to stop 3 months before to avoid or reduce the risk of teratogenicity, and so refer to contraception clinic for effective contraception. And what is the targeted BP here?
130, 80.
130 by 80 is targeted BP, not 140/90, which we normally do in case of pre-eclampsia or pre-pregnancy induced hypertension. Everyone, were you aware of this fact?
No, ma'am.
No,
No.
ma'am.
So this is a very important change in new guideline. Renal function, urine albumin creatinine ratio, echo as pulmonary hypertension, special eye checkup, heart MRI for iron overload. Definitely we are going to perform in preconception counseling. Iron chelation before if iron overload, because this is one thing which we cannot do in pregnancy. Vaccination is a very important point in preconception counseling, especially because this has to be addressed. Annual flu. In flu, you will include both influenza and swine flu and pneumococcal 1 in 5 years. Starting folic acid. If patient is not pregnant, is she supposed to take folic acid?
Yes,
1 milligram.
preconception.
How much? Not preconception.
5 milligram.
No, I'm not asking
No,
preconception counseling. I'm asking a patient
1
with
milligram outside the pregnancy, 5 milligram in pregnancy.
lovely. Lovely. High risk couple means when the woman is SCD patient and husband is carrier of beta globin variants like HBS, HBC, beta thalassemia, counsels about the option non-intervention prenatal diagnosis or pre-implant genetic. This is again addition in the new guideline. So you have to speak about this. Patient is coming for preconception counseling. You have to speak because this is a new addition. So whatever is the new addition, you have to address that because they expect from you that you must have gone through the changes, whatever they have made. So this is something very important you have to mention because, okay, now who is going to tell me if mother is diseased and husband is carrier? So what are the chances of having the condition and the traits in baby?
Ma'am, 50% chance of baby having the condition,
Hmm.
and rest all are careers. 50%
Right,
career.
all are career.
Why,
3 by
ma'am?
4 chance of having
100%,
the
yeah.
Sorry,
condition.
one by one. If you type, because when you speak, everyone's become so difficult for me.
Ma'am, 50% chance of having the disease, 50% chance of career.
Yes.
If patient is having condition, husband is a career.
Yes. Now, is it Aparna?
Yes, ma'am.
So now you said correctly. Earlier you said that one will having condition and rest will be having the fever seven. Hello, yeah, Bhumika, I'll send it tonight for sure. Okay. Okay, tell me one thing. If both are carrying traits or having traits or carrying carrier genes only, then what would be the outcome?
Ma'am, 25% having the condition, 50% career, 25% normal.
कैसे बना है? Can you tell me?
Ma'am, both are career, have the trait. So, ma'am, just cross, I mean, doing the pedigree, you know, S, bade wala S is 25% having the condition. Then rest with small s, 50% having the career, and
Okay, I'll make it easy for everyone. Everybody imagine one male and one female. Everybody, one male and one female. Male, so S is a yellow color because I'm mentioning everything important in yellow color. So there are two chromosomes. You just imagine two chromosomes. One is yellow color, that is straight. Another is blue, that is normal. So yellow, blue. So
Ma'am,
when
are you sharing the new screen? Because we are able to see only the old screen.
just a minute. Are you able to see now?
No, the old one only.
Which one?
PCC. PCC, IF
That is I'm
PCC.
showing. Only that one is I'm showing. No? This I'm just discussing. Now you can see important points.
Yeah.
So we are just discussing. I have not made any slide for that. This is just randomly I'm asking. So just imagine in your head, there is one male and there is one female. Yellow, there are two chromosomes in both, and yellow stands for sickle cell, blue stands for normal trait or like no trait. Okay. So now first combination be yellow meeting yellow, right? Female yellow meeting male yellow. Can you imagine that? Say yes or no, or I'll move forward, girls.
Yes, ma'am. Yes, ma'am.
Yes. So it is going to be diseased baby, right? Now female yellow and males blue, which is the second one. So it is blue and yellow. So this is going to be
carrier.
great. Then yellow, now mother's second, that is yellow, blue, and male's first, which is yellow one. So again, it is going to be a,
Carrier.
and now second mother's blue and father's blue, it is going to be a normal one. So it is very
Normal one.
easy to make pedigrees, really very easy. You have to just imagine in your mind, that's it. Clear? Same way,
Yes,
if you
ma'am.
now you imagine that women is having 2 yellow and male is having 1 yellow and 1 blue because he is carrier. So mother's first and father's first yellow meeting, it is making disease baby, right? Right?
Yes, ma'am.
Then it is father's yellow and mother's yellow and father's second blue meeting and making trait, right?
Yes, ma'am.
Then mother is having second yellow, and now it is going to meet father's first yellow, so it is going to be another,
Diseased.
and now mother's yellow is going to meet father's blue, it is going to be.
Trait.
So anyways, are you going to have a baby without any abnormal genes?
No.
No. So that's why it is very important for going for this prenatal diagnosis. Now there are certain important points. We have finished our task. If it is going to come, how you are going to address that? Now, important points. Pregnancy and conception should be discussed with women of childbearing age as a part of annual review. Whenever they come for review, whether she's planning or not planning, this is a very important guideline which is given that you have to discuss about pregnancy and conception. Everybody, please mute yourself. Folic acid 5 mg before throughout pregnancy, vitamin D3. Again, I emphasis, do mention this. Daily antibiotic prophylaxis. Stop. Angiotensin receptor blocker, angiotensin converting enzyme inhibitor, iron chelators. Who is trying to get pregnant, not after getting pregnant. Remember that. Do not say once you will get pregnant, we'll stop. No, once you will be planning for pregnancy, you have to stop. If partner is carrier, this is very important. A new change counseling at the first trimester itself, it affected fetus identified option of termination. If fetus identified affected option termination of pregnancy, this is very important change. MDT, that is pregnancy consultant, midwife who has experience in high risk antenatal care, blood doctor with a specialized blood disorder team. Aspirin, this is again a change. Now from 750, they have made this change. Aspirin 75 to 150 daily from 12 weeks till 36 weeks. After 36 weeks, they will review about it and they may consider to stop. Growth scan, definitely here difference from the other maternal medicine, that is 24 weeks onwards, 4 weekly. Transfusion, very important. You have to remember these 3-4 points. These are the changes from the previous guideline. These are the now recommended one. Consider if multiple pregnancy, current medical, obstetric, fetal problems related to SCD, acute SCD complications like acute chest syndrome or stroke. Here you will consider, I repeat. Okay, now you will repeat for me, okay? Offer women receiving long-term transfusion for stroke prevention throughout pregnancy, she will be getting it, and worsening anemia. So now everyone one by one repeat this. This is again a very important patient safety point. What if she asks, what if she is carrying multiple pregnancy? You should be aware of this. 4 volunteers, repeat loudly one by one.
Ma'am, shall I consider?
Yes.
Shall I start?
Yes.
So there are conditions in sickle cell disease where we can give transfusion. Number one would be a multiple pregnancy.
We can
Number two would
consider,
be,
mention there, consider. There's difference
okay, we
between.
have to consider blood transfusion. One would be multiple pregnancy. Second would be current medical, obstetric, or fetal problems. Acute sickle cell
If
disease
related to SCD.
if related, okay, if related to sickle cell disease.
Yeah.
Acute sickle cell complications, especially that of acute chest syndrome and stroke. And we have to offer blood transfusion to women who are receiving long-term transfusion for stroke prevention throughout the pregnancy or worsening anemia. Worsening anemia could be explained at HB less than 6 grams or a fall in HB more than 2 grams.
So now who is going
And
to answer, repeat this?
Ma'am, may I?
Yes, one by one without wasting time. I'm
Yeah.
already having 10 minutes more
So
than I
the
have to write up.
indications for transfusion, we consider if it's a multiple pregnancy, any complication, medical, obstetric or fetal related to sickle cell disease, or when there is acute complications like acute chest syndromes or strokes. But we offer in conditions where women are already on a long-term blood transfusions for stroke prevention throughout the pregnancy, or if it's a worsening of anemia, as correctly said, that more than 2 gram fall or less than 6 grams, especially at term.
So now three more volunteer. Trust me on that. If you speak something while seeing it, it is going to remain in your brain forever. It's a drill which is very important for your retention. 3 more volunteer quickly. Or otherwise I'll move on.
Yes, ma'am.
Yes, please. Yes, please. Raila, you want to speak? Girls, come on. Smart, be smart. You're getting an advantage to speak. What?
I'm having a background noise in my home because
It's
of some
fine.
construction work.
It's
Is it
fine.
okay?
It's fine. It's fine.
So, in the complications like acute chest syndrome and stroke, it will be exchange transfusion which will be preferred. Whereas if the patient was a transfusion dependent sickle cell disease, then we have to maintain her hemoglobin, and those patients will be receiving the transfusions. Anytime if there is a worsening anemia, like more than 2 gram percentage drop, or anytime I think less than 8, then she will be for transfusion as well.
Post-delivery. Baby handed over to baby doctor, eating, drinking, encourage breastfeeding, assess BTE. This I think we have discussed, no? Okay. Coming back to the PCC, important points. I think I went back. That's usual. Acute pain management. This is very important because it can come as SPT that patient has reported in emergency with pain. Very important points. Here, probably your task will be roaming around the acute pain management, because it is very, very long. First, immediately offering MDT, that is senior obstetrician, obstetric anesthetist, obstetric physician, specialist nurse, midwife. If it is mild pain, you start with mild pain, then you will include MDT. So first you start with mild pain. If he has come with the mild pain, rest, oral fluids, PCM, or weak opioids like codipropamol, codamol, dihydrocodone can be offered. And whoever was asking this question, caution in first 3 months and after 13 weeks. So it is preferred between 12 weeks up to 31 weeks. This is new guideline. If patient is having severe pain, then definitely you are going to include MDT, admission, strong opiates, morphine, diamorphine, which you can give either oral, subcutaneous, IV. Here, patient wish is very important to decide about the mode of, or the route of, sorry, not mode, a route of drug. So acute pain management, who's going to tell me about mild pain?
ma'am, I'll try.
Yes.
Yes. So whenever a patient in acute pain
Patient is
comes
there.
to us,
Patient is there. You're speaking to patient and talk about only
okay,
mild pain.
okay. So how are you feeling now? Okay, so don't worry. We'd be arranging a team of specialists, including our senior consultant, the pain management doctor, a specialist nurse, and a specialist midwife. We would be monitoring you throughout. We want to make sure that your pain is relieved within 20 minutes of your arrival. You can take oral fluids as per your thirst. To start off, we want to give you some mild painkillers like paracetamol. But if you're unable to achieve pain relief with that, we may upgrade it to some mild opioids like codridamol. Okay. In case it is not getting better with those drugs, we might have to give you certain strong drugs like strong medications like morphine. Okay, am I clear
Then
so
no, no,
far?
no, no. First, you will say admission. Do not compromise patient safety. If it is severe pain, first you will offer admission, then you will offer strong opiates.
Okay.
And do talk about this. This is patient safety that you are informing patient.
So usually, since you're in your 35th week of pregnancy, so usually we try to avoid giving NSAIDs. Okay, so we'll try to avoid giving those medications, and we have to
Now
start.
moving, that's it. Now moving further, analgesia within 30 minutes of arrival in hospital. Please, these are very small words, but very important because this again affects your patient safety. 30 minutes of arrival in hospital after initial rapid assessment. We have to do a very rapid assessment. We cannot waste, like you are just assessing patient for half an hour. Quick assessment and then quick analgesia within 30 minutes. So in 30 minutes, assessment followed by analgesia. Pain control within 60 minutes of starting analgesia. Again, it is not after arrival, it is after starting analgesia. So you do not get confused with this. Who is going to say this for me? What is the criteria of duration?
That analgesia should be given
Any
within
other
30 minutes.
any other volunteer also? I want volunteers there. Is it only Aparna? Is it Ishana or Aparna?
Aparna, ma'am.
So
If nobody
I
else
can
will
try.
speak, then yeah,
I can
please.
try.
Who is this?
Yes, ma'am, I can tell.
Yes, sir. So
Rahila is
Insha,
here.
is it Insha or
Yeah.
Laila?
Yeah.
Right?
So, yes, I'm Rahila.
Okay.
So, we will give you the pain medications as you are already arrived in the hospital. It's 30 minutes there, and the team of the we will be do
We
your
will
complete
quickly
assessment.
assess you for all your general well-being, temperature, and will give you pain relief within 30 minutes. Say,
Mhm.
say it properly.
So, we will assess you
We
quickly
will quickly.
in the form of your
Yeah, yeah.
uh,
Yeah,
in the
continue.
form of your blood pressure, your heart rate, and your pain score will assess and will give you the pain medication accordingly.
Within?
And then
Within?
within 30 minutes.
Yes.
And if your pain is not controlled, within after the 60 minutes of your, we give you the pain medication, then we will do the complete full set of the observation again.
Lovely. Full set of observation is Myo charting, that is blood pressure, pulse rate, respiratory rate, temperature, oxygen saturation, pain score, and repeat every 1 to 2 hours. This is again very important, which you are going to mention. After analgesia, assessment of pain, sedation, and respiratory rate in 20 minutes interval. Assessment of pain, sedation, and respiratory rate. So, what you assess after analgesia every 20 minutes? Chorus, please.
We have to assess for the pain score. We will be assessed for the patient if it's
For the
feeling
pain,
drowsy
sedation,
or
and respiratory
Pain,
rate,
sedation,
20
respiratory
minutes,
rate.
20 minutes.
and restful observation every 1 to 2 hours.
Yes. So this is 20 minutes. This is 1 to 2 hours. So 20 minutes pain, sedation, respiratory rate, and 1 to 2 hours. This. IV fluid to maintain hydration and 2 hourly. So what 3 criteria of duration, rather 4 criteria of duration we are having? Who's going to volunteer other than Aparna? If nobody is going to volunteer, then it is going to be Aparna.
Ma'am, I
Uh,
will.
so
Name
pain
please, name
control
please,
within,
name. First you mention name.
yeah, Maya.
Maya, okay, Maya.
Pain control should be started within 30 minutes, and we should take care that the pain should be completely controlled within 1 hour of duration of the.
No, pain arrival within, you didn't mention 30 minutes.
Yeah, so no pain, the analgesia, to start analgesia, it should be within 30 minutes.
Yes, this is what I'm asking.
Oh, yeah.
Mention
And then pain control should be achieved by 1 hour.
after
And then we need to, then we need to repeat the muse, which will include the blood pressure,
no, try
respiratory
to
rate,
remember.
temperature.
Maya, try to remember as per their
Yeah.
duration. So whatever is the lesser, speak that first. So that will be easy. After analgesia, first speak about this, then speak about this, then speak about this. Okay?
Okay. So we'll repeat the full set of observations, which will be included in the muse chart, and that is going to be repeated every 1 to 2 hours. And then last will be IV fluids. So IV fluids also we need to review about the hydration. So every 2 hourly we will be repeating the judgment about the fluids and hydration,
Especially
especially in a patient where we are
because we
suspecting
want to
high blood
avoid,
pressure.
because we want to avoid fluid
Yeah, to go for either nephrotoxicity or
fluid overload,
leukemia. Yeah.
fluid overload. Preeclampsia, what is the IV fluid rate we give in preeclampsia? 80.
80 ml per kg.
Yeah.
Who said 80 ml?
Aparna.
Okay, it is 80. So remember, in chronological order, you will never forget. 30 minutes, arrival,
Okay.
60 minutes after starting, then assessment after analgesia, that is 20 minutes, that is pain, sedation, respiratory rate. Every hour, Meo charting, you understand what we include. Other than that, pain score. Even pain score is also included there. So IV fluid every 2 hourly minimum, especially this. If your examiner asks why you are mentioning this, to avoid fluid overload. Because in SD, it may be just a question that kindly manage acute pain for this patient. So you have to start from here. And there you have to mention fluid overload. Now, oxygen maintain a 95%. So what is the criteria for this oxygen? What should be the minimum?
94.
95. So what is the difference? First is BP. What is the target BP?
130, 80.
130,
And what is the target saturation?
95.
Greater than
95. If less than, medical review to rule out any, what is this?
Acute chest syndrome
Or
pulmonary embolism.
or pulmonary embolism.
pulmonary embolism. This is not eclampsia, pre-eclampsia. This is pulmonary embolism.
Yeah.
And we
Yeah.
offer facial oxygen, early recourse to intensive care via face mask or nasal cannula. So if we find that patient saturation is less than 95, we will not wait for very long before shifting for intensive care. This is a very important point which you have to mention in SD. Assess for infection and urine routine and microscopy. Chest X-ray if patient is hypoxic or woman has any abnormality on chest examination. That's why I told you in examination, you are going to check her chest and heart. This is very important. Antibiotics as per hospital protocol, serially unwell from 24 weeks. If patient is severely unwell, then 24 weeks onwards. And from 28 weeks, daily continuous fetal monitoring with ultrasound. Right?
Ma'am, can I add one point about the timing?
Yeah, please.
So what I remember from sickle cell guideline that urine routine we are doing with all the with every visit for the
Hmm.
patient, and urine culture we are doing every monthly.
If you can remember this much, nothing like that. Nothing like that.
Yeah.
Nothing like that.
Yeah.
If you can really retain this much, then that's fantastic. But I'm just giving the guideline because once you go through all 180, 190 records, there are chances of mixing. So at least you should not miss the important point. If you can remember, then heads off.
Yeah, that's really important.
Okay. So this is again very important. Other than 24 weeks, 4 weekly, which we offer, we are going to offer fetal monitoring daily if severely unwell. What if the baby pregnancy is less than 24 weeks? What we are going to do in a severely unwell patient? Are we going to do any kind of monitoring for baby?
No, not
Just
for the baby.
droplets,
Not
No,
less
fetal
than
heart.
24.
no.
We
Okay.
can offer, yeah.
We do not offer any kind of vigorous monitoring or any kind of spatial ultrasound or daily fetal monitoring if it is less than 24. If it is more than 24, it is scan. And if it is more than 28, then scan plus daily monitoring.
CTG.
LMWH, CTG, LMWH prophylaxis during hospital admission. I think this everyone knows. Regular monitoring of fluid balance and the oxygen balance for admitted patient with sickle cell crisis. This is everybody is aware of this. Now, acute chest syndrome. What if your examiner wants to know that what if patient has developed acute chest syndrome, how you are going to manage this? 10% of pregnant women with SCD may develop acute chest syndrome. If you can remember this, good enough. Otherwise, I myself very bad in remembering percentage, but I could clear exam, so I do not think that it is very important. Fever and or respiratory. It's not necessarily that patient is going to have respiratory symptoms. So there may be respiratory symptoms or there may not be any respiratory symptom, but new infiltration on chest X-ray may be visible. What investigation you are going to offer? Full blood count, arterial blood gas analysis, chest X-ray, blood culture, sputum for microscopy, culture. Everybody, please mute yourself. Everyone, kindly.
For stabilization, once BP is stable, you can shift her to room.
Full blood count, arterial blood gas analysis, chest X-ray, blood culture, sputum for microscopy, culture, sputum, and nasopharyngeal aspiration for viral testing. For SD, please remember every line. Differential diagnosis is
Pulmonary embolism.
causes multifactorial. Causes for acute chest syndrome can be multifactorial. Acute chest syndrome treatment. First is pain relief. Second is incentive spirometry. Treatment of bacterial or viral infection. Blood transfusion early in hypoxic patients. Top up only in early and less severe. Exchange transfusion severe or lack of response for top up. Critical care team in severe or deteriorating patient to consider non-invasive or invasive ventilation. Following an episode of acute chest syndrome needs regular prophylactic blood transfusion. This is an important patient safety point, so I'm making in a different color. So when we offer prophylactic blood transfusion throughout pregnancy, anyone?
When there has been a case of acute chest syndrome in this pregnancy as a complication of sickle cell disease.
No. When the patient is already on repeated blood transfusions to prevent stroke.
Hello.
In acute chest syndrome, regular prophylactic blood transfusion following an episode of acute chest syndrome. This is a new guideline. Antibiotics to cover atypical organisms even if cultures negative. ये बहुत important. Who is going to repeat acute chest syndrome treatment because this may come in ST?
I'll try, ma'am.
Who is this?
Ma'am, it's Insha.
Come on, Insha, move.
So first of all, acute chest syndrome is a medical emergency in patients with sickle cell disease. They need a multidisciplinary care involving the critical care team, especially if the patient is having severe symptoms or is deteriorating. The treatment would revolve around pain relief. We have to give the patient incentive spirometry. We have to treat any bacterial or viral infections if the cultures or the blood results have shown so. Blood transfusion should be started early in hypoxic patients. Top up should be given in early or less severe patients. Now, any patient who has an episode of acute chest syndrome in pregnancy, which has required a blood transfusion, should be kept on regular prophylactic blood transfusions throughout the pregnancy.
This line.
Exchange transfusion should be given for severe cases or where there is a lack of response for the top-up transfusion.
So,
Antibiotics
yeah, continue.
should be given to cover atypical organisms, even if the cultures are negative.
So you'll start with pain relief. Then you speak about spirometry. Then remember, then this treatment of bacterial or viral by the antibiotics. Then remember this blood transfusion part. This is very important. If hypoxic patient, then blood transfusion early. If early and less severe, then top up. But if it is severe and lack of response, then exchange. So top up in early and less severe. If it is more severe and there is no, because first you have tried top up, right? But there is no response and now it has become severe. So remember that way. Patient has come, so we have immediately gave her top up, and patient was also not severe, so we gave her top up. But
Ma'am, what is top up?
Top up transfusion.
Simple what we usually
Top up
give.
transfusion, yeah. Okay, if patient is not responding to top up, and now she has become severe as well, so we'll immediately go for exchange transfusion. And if you need to give for ACS, then you have to give throughout pregnancy. Who is going to repeat the blood transfusion regime? This is very important.
Ma'am, I have a confusion. Ma'am, does this mean that antibiotics need to be given nevertheless? Because even if the cultures are negative, we are giving antibiotics, so we have to give
atypical
it.
organism. They have not mentioned what does they mean by atypical organism, but they are mentioning it separately. If there is
Atypical means, ma'am, I think
organism,
mycoplasma,
or maybe
which are not
this only.
grown on culture.
Yeah, so in that
Mycoplasma
case, they
only.
have to give antibiotics.
Okay.
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 So now who is going to talk about blood transfusion?
Yeah, ma'am.
Who is this?
Aparna.
Other than Aparna, anyone? Akansha?
Passbook.
Asma? Okay. So I have removed the slide. Now,
Yeah.
yeah, now speak. I've removed the slide. Now I'll see how much you remember. No one without slide? It's so easy to remember, no?
Which one, ma'am? You're talking about acute chest syndrome, no?
Yes, acute
For
chest
blood
syndrome. Just tell me about
Yes.
the blood transfusion regime which
So,
we offer.
Yes, so acute chest syndrome, it mimics like pneumonia. So patient will be treated starting from saturation. So we have to maintain the saturations of 95. And then
I'm
we
just
will be
asking
starting her.
about blood transfusion, Maya.
Okay, only blood transfusion, that's fine. So if the patient is already receiving the blood transfusion, and if she is a known case, then we will be giving her the top-up transfusion. So if she is not getting treated with top-up transfusion, then she will be the candidate for exchange transfusion. And what else? Yeah.
Blood transfusion early in
And
hypoxia.
also they might need the ventilator therapy, and that can be either invasive or non-invasive therapy depending upon the saturations.
Correct.
And
So-
then they will be also
Yeah,
needing the vaccine.
yes. So blood transfusion early in hypoxic patient, top up in early and less severe. But if she is not responding to top up and she is becoming severe or serious, in that case, you are going to offer exchange transfusion. And once if you need to give her a transfusion, then you have to give throughout her pregnancy. Antibiotic if there is any infection, but if there is any atypical, then in spite of negative culture, you have to offer her. Then pain relief, you are very much aware of what pain relief we have already discussed, and spirometry. Acute chest syndrome definitely can come as ST. Now acute stroke. Consider women with neurological impairment and require urgent consideration of exchange transfusion. So this is another indication of exchange transfusion if there is acute stroke and patient is presenting with neurological impairment. Again, this is a medical emergency, urgent brain imaging, refer to stroke physician, hematologist, rapid exchange blood transfusion, which we have already discussed, role of thrombolysis, acute erythrovirus, that is parvovirus B19 infection should be considered in women presenting with acute anemia like aplastic reticulocytopenia. Risk of vertical transmission, so fetal medicine referral, this is very important. And treatment is isolation and blood transfusion. Acute stroke patient, you are going to keep in isolation. This is patient safety because this is given only under acute stroke. So you have to mention that these are the new guidelines which they have made certain changes. So in acute stroke, if neurological, offer exchange transfusion, mention, say it is a medical emergency, then you are going for this brain imaging, that is in stroke, you know, this thing, then the rapid, which we have already discussed, thrombolysis, and the parvovirus. Mentioning parvovirus is very important. Now, VT, you know that, consider from 28 weeks until 6 weeks postpartum. If additional risk factor, then we can start from the beginning. If hospital admission, then LMWS. So these are the three criteria. 28 weeks, if additional risk factor, then beginning from pregnancy, hospital admission. What could be the additional risk factor?
PMI, preeclampsia,
BMI,
hypertension,
AIT,
disease,
age,
like diabetes
Renal
and eating.
involvement. Very important, renal involvement. Right?
Ma'am, sickle cell disease, we are giving it right from beginning, no? Why 28 weeks?
Again, the difference is that, again, who is this?
Maya.
Maya. Maya, actually, there are two kind of guidelines. One, what we follow for VTE, and one, what we follow for SCD. So if you are getting any task or any SD, it's my suggestion, follow whatever is given in SCD. Do not follow whatever is given in VTE guideline. Because for SCD, they are going to judge you through SCD guideline, which is the recent one. Okay?
And when is this new update came for the sickle cell disease? What you are saying?
When a few months, basically that hematology department of RCOG has taken over SCD. So they have archived the previous one.
Okay, all right.
Intrapartum care, consulate unit, hospital with critical care, then you understand and keep warm, educate hydration, fluid balance chart to avoid overload. Continuous CTG and static assessment in third trimester. This is very important. This is for the pain relief. Why we do this anesthetic assessment in third trimester? For discussing
pain relief.
Pain relief, that is analgesia and anesthesia both. Opiates. And for the anesthesia, we always prefer a regional over general. Now, postpartum care. 25% of sickle cell crisis more with GA. So why we not prefer GA?
It causes sickling.
Yes, because it causes sickle cell crisis. Patient is already at risk of developing, that is 1 out of 4 women. If we give GA, this risk increases further. Increased risk of pain, precipitants should be avoided. You know what are the precipitant or the risk factor? Hydration, oxygen saturation should be maintained. So again, this when we'll talk about the post-operative care to patients with early eating, drinking, moving around, you are also going to mention about that we will maintain your oxygen saturation. And what should be the level of oxygen saturation?
More than 95.
95.
95% or more than that. And again, whoever was having the doubt about NSAIDs, it is safe in postpartum and breastfeeding. No codeine. Why we do not give codeine in breastfeeding?
Cause the constipation and
Transfers to breast milk
With
and it
breastfeeding, so
For
if
the
I'm
baby,
saying
for the baby.
breastfeeding,
Yeah.
for the
means
baby
I'm
respiratory
asking,
depression.
sorry?
It causes respiratory depression in the
Yes,
baby. It gets
this is the
transferred to
difficulty.
the breast milk.
One of the tasks when patient is coming with infectious mastitis, if you read one small line in a very small word, they have given that patient is taking codeine. So in a case of postpartum mastitis, in a task, patient was taking codeine, which resulted in breathing difficulty and baby was little bit drowsy, was not able to feed, which caused mastitis. So this is one very important record. These are the certain which we can offer and we cannot offer this. This is dihydrocodeine, tramadol, low effective dose, shorter duration. This is again very important. You cannot give it for very long. Neonates at risk of neonates at risk of adverse effect of opiates. So definitely we are going to monitor baby. Infant monitoring for sedation, weight gain, difficult feeding, breathing difficulty, and constipation. This is patient awareness, patient communication, safety that you have to inform patient about postpartum care. So what all you are going to monitor in a baby up to 1 year of age?
तो पढ़ लिख लो, क्या बात हो रही है, बाद में कर लेना काम.
हाँ, बाद में कर लेना, अभी करना जरूरी है सब कुछ. कौन है ये जो सब कुछ अभी करना चाहता है? दीपिका?
Sorry मैम.
सब तंग करते, जैसे तुम लोग मुझे तंग करते हो, तुम्हारे बच्चे तुमको तंग करते हैं.
Sorry.
Okay. Who is going to tell me about infant monitoring? This is very important, patient safety. Okay, anyone who wants to volunteer about postpartum care, important points to be addressed. Fast, girls, this is last 2 slides. I have a session, darling.
Ma'am, may I?
Yes, yes.
So, ma'am, a patient, because there will be redistribution of the blood, so patient has to be carefully monitored for the PPH. And hydration, adequate hydration should be maintained, stress factors should be avoided, support should be provided for breastfeeding, and her saturations and this vitals should be monitored, and she should be assessed for thromboprophylaxis, balancing the risk of bleeding as such. So she can be provided with compression stockings as such and try to mobilize early on. Adequate pain relief should be given to provide to avoid any crisis as such. Paracetamol is the first line, and we should try to avoid NSAIDs and codeine as such, because then they can transfer in blood.
We
and
should
said
avoid
we can
this.
give.
We should avoid this.
NSAIDs, ma'am, they say कि it decreases the quantity of breast milk.
एक मुझे समझ नहीं आता, तुम लोग सिंपल छोड़ के कॉम्प्लिकेटेड उसमें क्यों चले जाते हो? Make your template simple. It is clearly given in guideline that it is considered safe, and you are just thinking about because it will decrease the breast milk. Please do not complicate your template. You just do not talk about the superficial basic thing and you try to go into the deep, which is probably not required. Trust me on that, Deepika.
Ma'am, but we can start with paracetamol na first. If she
Yes, you can definitely start paracetamol. Anyways, is absolutely safe throughout pregnancy, breastfeeding, because that is definitely safe. But what if, okay, leave it. What if your
yeah, it
examiner,
can be given.
just a minute. What if your examiner asks, if you say it should not be given, you will lose marks in applied clinical knowledge completely. So do not think beyond guideline. It's
Okay.
a request to everyone. Please do not go very deep. Just make your information superficial as per guideline. That will be more than enough to clear your exam. I don't know, but I'm noticing in this batch of May 24th that everybody is like going so deep and they're just leaving the very basic, superficial, basic points which are very important. Don't do that. It's my request. Okay? Move further. And speak about codeine.
Ma'am, codeine is not the first one because it is an opiate, so it can cause respiratory depression in the baby. So if codeine has to be given for pain, then we have to inform the pediatrician and observe the baby for any distress.
Which one we prefer?
Ma'am, light ones like coke, didramol, dihydrocodeine, they are the weak
Hydrocodone.
opioids.
Only go through guideline. In guideline, it is clearly given only these two. So do not think anything. Do not talk anything. Just whatever is given in the guideline, that is your Bible, that is your Gita, that is your Quran.
Okay.
Please, it's like, I don't know how to say this. Please do not do this to yourself. It's not going to affect my result, which is going to affect your result, darlings. Don't do this to yourself. You are really working hard. Everyone. Okay? Just stick to guideline. Guideline is not beyond even any mentor. So
yes.
whatever I have written here, Deepika, it is straight away I have taken from the guideline, which is the new one. Okay? So
Okay.
just now
Okay,
do not talk anything else. Just start from here and speak it nicely so everybody can remember this.
So in postpartum period, as there would be fluctuations in the blood volume, so patient can have a relapse. So there is a 25% risk of having a sickle cell crisis, and more so if she has been given general anesthesia. So we have to avoid the precipitants, like we have to hydrate the patient, mobilize her, give her adequate pain relief, and assess her for her observations should be taken half hourly. Till she's for at least 2 hours. So if she's in pain, the first line would be like paracetamol. But if paracetamol is not effective, she can have NSAIDs. And even if NSAIDs are not effective, then opioids may be given, but the weaker one like dihydrocodeine or tramadol, they can be given. But baby has to be monitored for any respiratory depression
Less effective
and any poor
dose
suckling.
and shorter duration. Less effective dose and shorter duration.
Yeah, it has to be given for the shorter duration. Yes, ma'am. And baby may even show withdrawal symptoms, then a pediatrician has to be informed and kept in the loop as such. And
Neonatologist, not pediatrician, neonatologist.
okay, neonatologist. And then the patient even has to be assessed for her this thromboprophylaxis. So we have to try her mobilize early, give her stockings and compression stockings. And
Infant monitoring. Tell me how you are going to monitor infant.
watch the baby for like sedation, excessive crying, sedation, any tremors, breathing difficulties, or constipation because of the opioids.
So we will monitor baby for sedation, weight gain, feeding and breathing difficulty and constipation, compression stocking and LWS. Contraception, these are the contraceptions.
Yes, ma'am.
Preferred one are
Depo-provera is the preferred one because it even prevents sickling.
it is something which you are not supposed to follow daily, right? And this why we prefer this, because this reduces this.
Sickling
And
crisis.
only if there is no cardiovascular risk.
Then only CHCs. And that even if patient is breastfeeding, we have to assess her at 6 weeks for that.
Okay. Now this is about vaccine, hepatitis B, conjugated meningococcal, H influenza. This is all once. Pneumococcal once in 5 years. Influenza and swine flu every year. So if you want to say flu, then it's fine. If you want to say influenza, mention swine flu as well. That's all for today. So
Excuse me, ma'am.
because I'm having another session.
Ma'am. Ma'am, they say that Deepika, meningococcal and they say Heb, they are to be given if patient has had splenectomy.
In new guideline, I didn't find anything. If I find
Me too,
something like this, then I'll definitely get back to you.
In thalassemia one, they have mentioned like Hib and this meningococcal have to be given only in splenectomized patient.
So that I'll go through for this sickle cell disease because I've gone through. I didn't find any such mention in new guideline. So I'll go through and I'll get back to you in group itself. Okay.
Thank you, ma'am.
So goodbye. And
Bye,
I'm
ma'am.
joining
Thank
that
you, Dr.
session.
Pooja. Thank you so much. Thank
Yeah,
you.
it was very difficult. Trust me on that. And it took almost 24 hours for me to go through the guidelines completely, the new one, and making it simple for you. So I hope it was helpful for you.